Hey everyone, welcome to our third video of the Neurology series. So today in this video, we're going to discuss about cerebrovascular disease, one of the most important and high-yield topics in neurology for the USMLE and NEET PG. We'll focus on ischemia, stroke patterns, vascular territories, brainstem syndromes, and hemorrhages. I would like to happily let you know that we have now officially collaborated with UWorld Medical, and you can use the code Varun10 to get an exclusive 10% savings on their medical library subscriptions and bundled QBank plus medical library packages. This medical library is not something new, it's already there. It's existing since 1 or 2 years already. But one thing that have come very recently forward is with their powerful AI-powered tool called as the You Ask, where we can just ask anything related to at least any single word that's on their medical library. We can ask it. We can ask any kinds of doubts we get whenever we have been studying for our steps. So this medical library is something that definitely helps us learn faster with an integrated all-in-one content. This UWorld is something that's trusted by millions of people worldwide. It's the gold standard for USMLE prep. Not only for USMLE prep, this medical library is also helpful for students who just want to learn something in their wards or rotations or their clinical postings. You can access the medical library through the link that is pinned in the bio, and you can get an exclusive 10% savings on their medical library using my code Varun10. This lecture series is provided free and is open access for everyone. There are no paywalls or mandatory fees collected from the students, and we don't get any fixed funding from any kind of organization. Only the voluntary support is something that helps us keep moving forward. So you can contribute to our cause with the link that is on the screen, and that's also pinned in the description. You can contribute to us with any of these payment methods. So uh, we can just discuss about strokes right now. So strokes are broadly divided into two different types. So ischemic strokes, which account for about 80 to 85% are one kind of strokes, and the other kind is the hemorrhagic strokes, which accounts for the remaining 15 to 20%. So now here's a critical concept. So neurons, they are something that they do not store glycogen. That means they depend entirely on continuous blood supply for glucose. So, if blood supply stops, irreversible brain injury can begin in about 5 minutes. So, that is why we call stroke a medical emergency. One thing to remember about stroke is that neurons have no glycogen reserves. Only thing that helps them keep functioning is continuous supply of blood for glucose. So, if blood glucose supply stops or if blood flow stops, there is irreversible brain injury that can begin in about 5 minutes, and that's the reason why we call it a medical emergency. So, time is the brain. We need to act fast in case of strokes. When blood flow decreases, neurons are deprived of oxygen and glucose, leading to neuronal necrosis or neuronal death. But not all the neurons are equally vulnerable. So, the most sensitive areas are the hippocampus, especially the CA1 region. The other sensitive cells are the Purkinje cells in the cerebellum. They are also highly sensitive to ischemic injury, whereas pyramidal neurons in the cerebral cortex are also vulnerable to ischemia. So these are first to die in hypoxia, and these are very commonly tested. The CA1 pyramidal cells in the hippocampus are the first to be damaged. Then the Purkinje cells in the cerebellum are highly sensitive. And finally, pyramidal cells, the neocortex, are also highly vulnerable to ischemia. So now coming to watershed infarcts, these infarcts occur at the border zones between major arteries, like between the anterior cerebral artery and the middle cerebral artery. So these watershed areas are already relatively underperfused. So during severe hypotension, like in cases of shock, these regions are the first to infarct. So that's the reason why we call them an watershed infarct. So now let's try to understand about the histology timeline in cases of ischemic stroke. In the first 12 to 24 hours, so at this stage, we see red neurons. They appear red because of eosinophilic cytoplasm, and their nuclei become shrunken, which we call as the pycnotic nuclei. This is the earliest histological sign of irreversible injury. Red neurons along with the pycnotic nuclei are the earliest histological sign in cases of irreversible injury. Red neurons are neurons that appear shrunken with intensely eosinophilic cytoplasm. They have an eosinophilic cytoplasm. Cytoplasm stains bright pink due to protein denaturation. Pycnotic nuclei are the nuclei that are shrunken, dark, and condensed. So this is the earliest microscopic change after ischemia. In the next 24 to 72 hours, necrosis now starts becoming prominent. So the brain starts showing liquefactive necrosis and neutrophils start infiltrating in the tissue region. So this reflects an acute inflammatory response, and this happens at around 24 to 72 hours after stroke. Necrosis is the affected brain tissue. The affected brain tissue undergoes necrosis, and neurons lose their normal structure and nucleus. Neutrophil infiltration also begins in the 24 to 72 hours timeline. Neutrophils migrate to the ischemic area and infiltrate the damaged tissue. So at 3 to 5 days at this stage, macrophages, specifically microglia, start clearing the debris. So they phagocytose dead neurons and necrotic tissue. At around 1 to 2 weeks, uh, the repair process begins. So we can see reactive gliosis happening. Reactive gliosis is nothing but astrocyte proliferation, where the astrocytes proliferate and hypertrophy in response to injury. So GFAP positive astrocytes increase. We have already discussed in the previous, in the first module of our neurology series, that this astrocytes are GFAP sensitive. The GFAP can be used as a marker for these astrocytes, and in reactive gliosis, there is astrocyte proliferation occurring. And also, there's new blood vessel formation at around 1 to 2 weeks. So, new capillaries grow into the infarcted area to restore perfusion. So, part of the repair and healing process mostly occurs in the 1 to 2 weeks timeline. So, this is the brain that's attempting to heal. The brain begins to repair itself by forming support cells, astrocytes, and new blood vessels. At around greater than 2 weeks, after 2 weeks, eventually a glial scar starts forming. So, and the damaged area may become a cystic cavity eventually. So, this is the final stage of infarct healing. Glial scar formation is characterized by dense proliferation of astrocytes forming a glial scar and forms a physical and chemical barrier that limits further damage. And there's also something that's called as the cystic cavity that develops. The necrotic tissue is completely resorbed, leaving a fluid-filled cavity. This represents the final stage of healing after an infarct. At this stage, the infarcted area is replaced by a glial scar or cystic cavity, and this happens at around after 2 weeks. This is the final stage of recovery after an ischemic stroke. Now let's try to understand about the different types of ischemic stroke. There are three major types of ischemic stroke. The first one is the thrombotic ischemic stroke. The second one is the embolic ischemic stroke. And the third kind is the lacunar ischemic stroke. So each of these have a distinct mechanism and clinical pattern. So thrombotic ischemic stroke is characterized by the development of an atherosclerotic plaque that is associated with luminal stenosis or luminal narrowing. This usually occurs in large arteries. It is associated with progressive symptoms, and also common risk factors for the development of this thrombotic ischemic stroke are hypertension, diabetes mellitus, HLD, and smoking. Now, coming to embolic ischemic stroke, the embolus travels from a distant site and occludes an artery. The embolus originates from the heart, most commonly seen in cases of atrial fibrillation, valvular disease, and mural thrombosis, or also from the proximal arteries, like the subclavian arteries. This is usually of sudden onset and is maximal at the start. It often affects large vessels. It can cause multiple injuries. Whereas coming to lacunar ischemic stroke, there is occlusion of small penetrating arteries or the lenticulostriate branches due to lipohyalinolysis and microatheroma of small vessels. This causes small, deep infarcts, usually of size less than 15 millimeters. This could cause classic lacunar syndromes, and it is strongly associated with chronic hypertension. So, all these three types usually lead to focal brain ischemia, but they differ in the mechanism. Thrombotic, characterized by thrombosis, embolic is characterized by an embolus that dislodges and travels to another site, and lacunar is characterized by occlusion of the small lenticulostriate branches of arteries. Now let's try to understand about thrombotic ischemic stroke much deeper. So this thrombotic stroke occurs when a clot forms at the site of atherosclerosis. So there's in situ thrombosis at the site of the atherosclerotic plaque. First, the atherosclerotic plaque develops due to lipid accumulation, and this is followed up by clotting of blood cells, leading to the formation of a thrombus. So this thrombus can lead to a luminal narrowing and luminal blockage eventually. The common locations of thrombus formation includes the middle cerebral artery bifurcation and the internal carotid artery. So they usually produce pale infarcts because there is no kind of reperfusion happening in these thrombotic cases. It is caused by local thrombus formation over atherosclerotic plaque, usually affects large arteries like MCA and ICA. Infarct is typically large and cortical or subcortical. This leads to pale infarcts because of ischemic necrosis. Now, coming to embolic ischemic stroke. So, in embolic stroke, the clot comes from elsewhere, so commonly the heart in conditions like atrial fibrillation. The embolus forms at a distant site, most commonly the heart, and travels through the circulation and occludes an intracranial artery, most commonly the middle cerebral artery. So, atrial fibrillation is a common source where the embolus travels and occludes the MCA. So, this is a typical pattern that we need to be vigilant about in any questions on the USMLE. So the common sources includes cardiac causes could be mostly seen with atrial fibrillation, which is the most common cause. Atrial fibrillation is something that has to come to your mind whenever you suspect embolic ischemic stroke. MI, valvular disease, and ventricular thrombus. There's an artery to artery emboli also possible, but it's usually less common, and also paroxysmal emboli, where in cases of patent foramen ovale with deep vein thrombosis, we can usually see paroxysmal emboli developing. These are sudden onset, often severe. It often affects large arteries, MCA being the most common thing. Embolus usually lodges at the arterial bifurcations, and there is a high risk of reperfusion injury. Reperfusion could lead to a hemorrhagic infarct, a red infarct. This usually have worse prognosis compared to thrombotic strokes. Reperfusion in embolic stroke. There is occlusion by embolus. Reperfusion can lead to hemorrhagic transformation. Now, coming to lacunar ischemic stroke. So these are small infarcts less than 15 millimeters in size due to occlusion of small penetrating lenticulostriate branches of arteries. It is classically associated with chronic hypertension and diabetes mellitus. Common risk factors of lacunar ischemic stroke includes chronic hypertension, diabetes mellitus, lipohyalinosis of small penetrating arteries, and this is more common in older adults. So lipohyalinosis is usually associated with narrowing and occlusion of small penetrating arteries. This could result in small, deep lacunar infarcts, typically less than 15 millimeters in diameter. This is associated with sudden onset of pure motor, pure sensory, sensory motor, or ataxic syndromes. There are no cortical signs, there's no aphasia seen, there's no neglect seen, and there's no hemianopia even. It has better prognosis compared to large vessel strokes because less uh, smaller regions are affected. Common locations of these lacunar strokes could be basal ganglia and internal capsule involvement. Basal ganglia involvement could lead to pure motor hemiparesis and also movement disorders, whereas internal capsule involvement could lead to pure motor or sensory deficits and sensory motor syndrome. Other possible locations includes the thalamus and pons. So coming to the lacunar syndromes, they produce very specific syndromes. Pure motor stroke is associated with a lesion in the internal capsule, a lesion in the posterior limb of the internal capsule. Clinical features could be weakness of face, arm, and leg on the opposite side of the body. There is no sensory loss. There are no cortical signs, no aphasia, no neglect. Uh, Cause of this is lacunar infarct in the internal capsule. This is associated with pure motor hemiparesis, usually on the ipsilateral side. Now coming to pure sensory syndrome, this is associated with a lesion of the ventroposterolateral nucleus of the thalamus. there is numbness or decreased sensation on the opposite side. Sorry, it's not the ipsilateral side, it's the contralateral side. Again, coming to the pure sensory syndrome, it's also seen on the contralateral side. There is numbness or decreased sensation. There is absent weakness. There isn't any kind of weakness. In pure motor, internal capsule involvement, there is weakness, whereas in VPL involvement, there is absent weakness. And there are also no cortical signs, no aphasia, and no neglect. Lacunar infarct in ventroposterolateral nucleus of the thalamus could lead to pure sensory syndrome on the contralateral side. Lacunar syndromes are pure because they affect only one type of function. Either it could be either motor involvement or it could be either sensory involvement. And cortical signs are definitely absent in both pure motor and pure sensory hemiparesis. Coming to the vascular territories, so we need to discuss about different vessels that supply the brain and the nervous system. So, coming to the first thing that we need to discuss is the MCA territory. So, the middle cerebral artery supplies the face and the lateral surface of the cerebral uh, supplies the lateral surface of the cerebral hemisphere. It supplies the face and the upper limb more commonly than the lower limb. So, if the dominant hemisphere is affected, this could lead to aphasia. If the non-dominant hemisphere is affected, this could lead to neglect of one side of the space or something that's called as hemi-neglect. This is one of the most tested stroke patterns on the USMLE. So MCA territory, so MCA is nothing but the middle cerebral artery. It supplies the lateral surface of the cerebral hemisphere. The MCA supplies the lateral frontal lobe, lateral parietal lobe, and the superior temporal lobe, and also the insula. So this is the MCA that we can see in the image. So MCA stroke affects the contralateral face, contralateral upper limb, and also contralateral lower limb. But face and upper limb involvement is more when compared to the lower limb involvement. So if the dominant hemisphere is affected, this could lead to aphasia. Common types includes Broca's or expressive aphasia and Wernicke or receptive aphasia. Whenever there's involvement of non-dominant hemisphere, usually the right, so this could lead to hemi-neglect where the person just ignores the opposite side of the body and then they may bump into objects or ignore people on that side. MCA stroke typically causes contralateral weakness and sensory loss, with face and upper limb more affected than the lower limb. Dominant hemisphere involvement could lead to aphasia, non-dominant hemisphere involvement could lead to hemi-neglect. Now coming to the ACA. So the anterior cerebral artery supplies the lower limb region more predominantly. So whenever there are deficits in this ACA territory, this could lead to weakness in the legs more when compared to the arms. It's also associated with urinary incontinence, which is commonly seen in these patients with ACA territory involvement. So anterior cerebral artery supplies the medial surface of the cerebral hemisphere. ACA supplies the medial frontal lobe and the medial parietal lobe. So this artery, which is labeled in this image, is the anterior cerebral artery, and this is the territory that's supplied by the ACA. ACA stroke typically causes lower limb weakness more than the upper limb, and also upper limb weakness could also be seen. It's usually mild or minimal, and the urinary incontinence could also be present in cases of ACA territory involvement. ACA stroke typically causes lower limb weakness more than upper limb weakness, along with urinary incontinence. Coming to PCA territory, so the posterior cerebral artery supplies the visual cortex. The key feature in this involvement is homonymous hemianopia. Macular sparing also occurs because the macula has uh, dual blood supply. So macular sparing is a possibility in this homonymous hemianopia cases. Patients may also develop visual agnosia. So posterior cerebral artery supplies the occipital lobe and the inferior medial temporal lobe. Uh, so this is the artery that's labeled in the image. This is the PCA, and this is the territory that is supplied by the PCA, the occipital lobe and the inferior medial temporal lobe. Clinical features of PCA territory includes homonymous hemianopia, where there is loss of the same side of the visual field in both the eyes. It could be either right or either left. Then we need to discuss about macular sparing, which is a very common possibility in PCA territory involvement. So whenever you see something that's related to stroke and the question mentions macular sparing, you need to think about PCA territory involvement. So central vision is often preserved due to dual blood supply. The central area is usually supplied by dual arteries. So that's the reason why macular sparing occurs in these cases. Also, visual agnosia is possible, where the patient is just unable to recognize objects despite an intact vision due to occipital involvement. The vision might be intact, but he might not be able to recognize objects despite an intact vision. PCS stroke classically causes homonymous hemianopia with macular sparing, and this may also lead to visual agnosia. Now coming to the brainstem. So brainstem is something that's very high yield on the USMLE, and we also need to discuss about the rule of force. So we need to localize the affected region in brainstem depending on the clinical features which the question mentions or which the patient just expresses, or on symptoms and signs, or what we find on examination. So this is a powerful localization tool. So this rule of four is a powerful localization tool. Brainstem lesions usually cause crossed findings, meaning that cranial nerve deficits on one side could lead to a body deficit on the opposite side. So this helps us localize the lesion quickly. So this rule of four helps us localize lesions very quickly. So four cranial nerves on the same side of the lesion. So these includes cranial nerve, and there are four long tracts, motor and sensory, four typical brainstem syndromes, and four important vascular territories that we need to learn about: PCA territory, ICA territory, PICA territory, and SCA territory. PCA stands for posterior cerebral, anterior inferior cerebellar, posterior inferior cerebellar, and superior cerebellar artery. Whenever there's brainstem lesion at any level, there are crossed findings. This could be associated with ipsilateral cranial nerve deficits or contralateral cranial nerve deficits. This could be associated with weakness, numbness, loss of pain, or temperature. Ipsilateral cranial nerve involvement could lead to contralateral body deficit. Coming to the lateral medullary syndrome, that's associated with the pica. So this is also called the Wallenberg syndrome. Wallenberg syndrome. So the key features of this lateral medullary syndrome could be difficulty swallowing, hoarseness, reduced gag reflex due to afferent limb involvement. So it's most commonly the glossopharyngeal nerve. And also there's loss of pain and temperature on the opposite side of the body, and also there's ipsilateral Horner syndrome. So this is a classic exam pattern. Whenever there's dysphagia and hoarseness, we need to suspect nucleus ambiguous involvement. There could be reduced gag reflex. There could be ipsilateral ataxia. There could be ipsilateral Horner syndrome due to descending sympathetic tract involvement. And also there could be contralateral loss of pain and temperature sensations due to spinothalamic tract involvement. So PICA stands for posterior inferior cerebellar artery. PICA supplies the lateral medulla and the inferior cerebellum. So nucleus accumbens involvement could be associated with dysphagia, hoarseness, and reduced gag reflex. Inferior cerebellar peduncle could lead to ipsilateral ataxia. Descending sympathetic tract involvement could lead to ipsilateral Horner. Spinothalamic tract involvement could lead to contralateral pain or temperature loss. So lateral medullary syndrome, dysphagia, hoarseness, reduced gag, ipsilateral ataxia, and Horner syndrome, and also contralateral loss of pain and temperature are usually seen. So this is the pattern that we need to remember about lateral medullary syndrome. Now, coming to the lateral pontine syndrome, usually due to anterior inferior cerebellar artery involvement. This ICA supplies the lateral pons and the anterior inferior cerebellum. So the features that are seen in this patient includes facial nerve involvement. So facial nerve involvement could be associated with ipsilateral facial paralysis, usually of lower motor neuron type. There is loss of taste sensation in the anterior two-thirds of the tongue because of uh, involvement of facial nerve, and usually the chorda tympani provides sensory taste sensation innervation to the anterior two-thirds of the tongue. There could be hyperacusis or also deafness. So the features of lateral pontine syndrome are similar to the features of the lateral medullary syndrome, but one additional feature that could be seen in this ICA involvement could be facial nerve involvement. In addition to the features that are seen in lateral medullary syndrome, there could be dysphagia, hoarseness, reducing gag reflex, ipsilateral ataxia, ipsilateral Horner syndrome, contralateral pain or temperature loss. And in addition to all of these, there will be facial nerve involvement leading to facial paralysis, lower motor neuron type, loss of taste sensation of the anterior to the tongue, deafness, and hyperacusis could also be seen. It is same as ICA, it is same as PICA, but there is facial nerve involvement, paralysis, loss of taste sensation, and deafness. Coming to the medial medullary syndrome, it usually occurs due to anterior spinal artery occlusion. So, anterior spinal artery supplies the medial medulla, usually the pyramids, the medial lemniscus, and the hypoglossal nerve. There is weakness on the opposite side of the body. So, there is contralateral hemiparesis. There is loss of vibration and position sense on the opposite side of the body again. And also, there's deviation of the tongue towards the side of the lesion, that is ipsilateral tongue deviation because of hypoglossal nerve involvement. So the clinical features that could be seen in medial medullary syndrome or ASA involvement could be usually contralateral hemiparesis, contralateral reduced vibration and proprioception sense, and also ipsilateral tongue deviation because of cranial nerve valve involvement. So contralateral hemiparesis could be a possibility, contralateral reduced vibration sense, and ipsilateral tongue deviation. So whenever there's motor weakness, loss of vibration on the opposite side and tongue deviation to the same side, you need to suspect medial medullary syndrome, and this usually happens because of anterior spinal artery occlusion. Coming to Weber syndrome, so this is a midbrain stroke. So it is caused by branches of the posterior cerebral artery or because of occlusion of the PCA. This PCA involves the PCA territory involves cerebral, peduncle, and cranial nerve 3 fascicles. So the features that could be seen in this Weber syndrome includes third nerve palsy on the same side of the uh, same side. So eyes down and towards the outside. So there's weakness on the opposite side. Again, in this Weber syndrome also there are crossed findings. So it's usually associated with ipsilateral cranial nerve 3 palsy, ipsilateral oculomotor nerve palsy, and also there's contralateral hemiparesis. Weber syndrome, because of PCA involvement, could be associated with ipsilateral cranial nerve 3 palsy and contralateral hemiparesis. There is weakness on the opposite side and eye involvement on the same side in case of Weber syndrome or PCA involvement. There are four major types of intracranial hemorrhages: epidural, subdural, subarachnoid, and intraparenchymal. So each of these hemorrhages usually have distinct causes and imaging features. Epidural hematoma is an arterial bleeding, usually the middle meningeal artery. It's usually lens-shaped, it's biconvex, and it does not cross the suture lines. Coming to subdural hematoma, it is associated with venous bleeding. Uh, involves the bridging veins more commonly. It's usually crescent shaped and it can cross the suture lines. Subarachnoid hemorrhage is characterized by bleeding into the subarachnoid space between the arachnoid matter and the pia mater. It's usually due to a ruptured aneurysm. Whereas intraparenchymal hemorrhage is associated with bleeding within the brain parenchyma. It's usually due to hypertension, amyloid angiopathy, arteriovenous malformations, and trauma. So epidural, arterial, lens-shaped, no suture crossing. Subdural, venous, crescent-shaped, crosses sutures. SAH, there is blood in the subarachnoid space. There is associated aneurysm, and intraparenchymal is associated with bleeding within the brain tissue. Now let's try to differentiate between epidural and subdural hematoma. Epidural hematoma is usually an arterial bleed, and most commonly the middle meningeal artery could be the involvement could be the most common possibility. It's usually this epidural, whereas subdural hematoma is usually associated with venous bleed, and it most commonly involves the bridging veins. This epidural hematoma is associated with the lucid interval, which means a transient uh, hyperactivity, a transient hyperaware state before losing consciousness. which is characterized by excessive talking and shouting. And this is usually seen on CT scan as a biconvex uh, lens-shaped lesion. So, whereas subdural hematoma is usually crescent shaped on CT scan, it's common in elderly due to brain atrophy. And this brain atrophy could lead to commonly venous bleeds due to involvement of bridging veins. Subarachnoid hemorrhage is usually due to rupture of a berry aneurysm. Uh, Classic presentation in cases of subarachnoid hemorrhage could be that the patient would say that it's the worst headache of his or her life. So the classic clinical presentation, and not only uh, on the exams. So on the exams, whenever the question mentions worst headache of life, it could be mostly, and the first thing that should get into your mind is subarachnoid hemorrhage. Not only on the exams, but whenever a patient just mentions that he has had the worst headache of his life, you need to think about subarachnoid hemorrhage because it's that worse. The pain is that severe that they would call it worst headache of their life. This is usually due to rupture of berry aneurysm. This berry aneurysm is usually seen at the anterior communicating artery. So this berry aneurysm at the anterior communicating artery, as you can see in this image, so there's a characteristic berry aneurysm. And whenever this ruptures, this could lead to subarachnoid hemorrhage. Diagnosis can be done using lumbar puncture, which shows xanthochromia, or which is just yellowish discoloration of cerebrospinal fluid due to breakdown of the RBCs. Lumbar puncture shows xanthochromia, and the patient calls it the worst headache of life. Coming to intraparenchymal hemorrhage, so it's most commonly caused by chronic hypertension. Mechanism of this could be rupture of small vessels or Charcot-Bouchard microaneurysms, where there is lipohyalinosis of small penetrating arteries. Location of this intraparenchymal hemorrhage could most commonly be the basal ganglia, especially the putamen. Most common location of intraparenchymal hemorrhage is the basal ganglia. There is sudden focal neurological deficit, and risk factors for this intraparenchymal hemorrhage could include diabetes mellitus and chronic hypertension. Whenever there's hypertension, this could lead to small vessel disease or Charcot-Bouchard microaneurysms where there is lipohyalinosis of small penetrating arteries, and this could lead to hemorrhage into the putamen. And this putamen involvement is the most common location of intraparenchymal hemorrhage. Now, coming to aneurysms. So, aneurysms are something that are very highly tested on the USMLE. So, berry aneurysm is the first thing that we need to discuss about. So, this berry aneurysm, these occurs usually at the circle of Willis. So, it's usually associated with polycystic kidney disease, connective tissue disorders like Ehlers-Danlos syndrome. So, saccular or berry aneurysm most commonly occurs at branch points of the circle of Willis. So, this is associated with autosomal dominant polycystic kidney disease and Ehlers-Danlos syndrome. Coming to compression of the aneurysms. So, aneurysms can compress the nearby structures, and they could also rupture, which could be fatal. So, compression by these aneurysms is a very common possibility whenever there's uh, a compression of the anterior communicating artery. Whenever there's an aneurysm at the anterior communicating artery, this could lead to compression of the optic chiasm, and there could be loss of peripheral vision. In these cases of involvement of the anterior communicating artery, bitemporal hemianopia is a very common possibility where there is loss of peripheral vision on both the sides, on both the eyes. So the characteristic visual field defect in bitemporal hemianopia looks like this, where the temporal sides of both the eye visual fields are usually affected. Now, coming to the posterior communicating artery aneurysm, this could lead to compression of the third cranial nerve, also called as the oculomotor nerve. And this oculomotor nerve involvement could lead to cranial nerve 3 palsy, where there is a blown pupil or dilated pupil. This is associated with ptosis, down and out eye, and mydriasis or blown pupil. Anterior communicating artery aneurysm compresses the optic chiasm and could lead to bitemporal hemianopia, whereas posterior communicating artery aneurysm could compress the oculomotor nerve and lead to oculomotor nerve palsy, which is characterized by mydriasis, or dilated pupil. Now we'll try to revise that we have discussed in this module, everything that we have discussed in this module. So ischemia, after 5 minutes, it's irreversible. The damage is irreversible. Red neurons appear within 12 to 24 hours. Lacunar strokes are usually due to hypertension, which is associated with lipohyalinosis. Hyalinosis. Middle cerebral artery affects the face and arm more commonly than the leg, whereas posterior cerebral artery usually affects the vision because of occipital lobe involvement. Posterior inferior cerebellar artery causes swallowing difficulty. It could lead to dysphagia, vertigo, and ataxia. So the spica involvement is also called as lateral medullary syndrome. Whenever there's epidural hematoma, this presents with a lucid interval. I hope this video helped you. If this video helped you, I would like to request all of you to subscribe and keep supporting. In the next video, we're going to discuss about CNS infections. Thank you so much. Bye.